Essentially, I want to tell you 3 stories, and the way that this works is in our clinic, we do all the metabolic work in ExoHealth, and then patients that opt in to come and do an EEG and brain treatment do that right next door in our brain health restoration clinic. Every Thursday, I review the findings with the neurology group that's based out of Newport Beach, and so you're going to see some clinical stories and some brain tracings to show you kind of the changes. So the first patient I want to tell you about, this is a young man, 53 years old young. Since he's my age, I call him young. But 53-year-old male who has a long, long history of falling back and forth in and out of severe alcoholism and its sequelae. So he's a person who has rehabbed more times than he wishes to admit, and with each of the episodes where he really was in severe alcohol use, he's had multiple head injuries along the way as well. He has had severe anxiety. He would say the anxiety might have been one of the underlying triggers that he was self-medicating with his alcohol. And he has also many medical complications of alcohol use over the years. So when he showed up, he had been told, this is it. There's nothing more. Your liver is at the point that you're done. Another drink, there's nothing more to do for you. So this was kind of his Hail Mary. Part of the Hail Mary is treating whatever's going on with his anxiety that he's treating with alcohol, but the other part of this is that he has not been able to have the, and I'm going to say quote unquote, willpower to not fall back into drinking. And I think we see really good evidence, Eric, with what you showed today as substance use in the region of the brain that's literally wired differently and upregulated. There was a reason that he has relapsed over and over. And so we put him into treatment in our clinic. His initial EEG, you'll see on the far left of this picture. The way the EEG works, across the bottom is the speed. So to the far left is 1 hertz, 1 cycle per second. When you see the 5, that means there's 5 cycles per second, 10 cycles per second. So when I said the average adult is at about 9.6, we would expect for most of us in the room to see about a 9.6 in some iteration. But Alex, join me if you would. And I'll give you the handheld mic. You got it? You're loved? Yeah, okay, perfect. So talk us through what you see in the very first EEG, that's the far left EEG.
Sure. Baseline taken September 10th, 2019. What we note in the back of the brain, posteriorly, you see how there's a little peak at about 9 hertz. And we'd like that to be nice and robust. We'd like to see that same peak and same frequency in frontal and central regions as well. And we can see when we look at his frontal lobe, frontal and central regions, we ask the question, how is the front of his brain talking? Well, it's at a different speed, slower. It's more so in this 5.5 hertz range. And just as review, 4 to 8 is theta. That's how our brain works when we're half awake, half asleep. So his frontal lobe's working as if it's not quite all there, half asleep, so metabolically very slow. And posteriorly, that very wide peak just says that, hey, over the course of the 10-minute eyes closed EEG he had taken, his brain isn't stable in a single way over that course in time. It's slowing down, it's speeding up, it's not really stable over time. And we can see in this middle EEG, this is after an initial round of MeRT, brain training, daily stimulation. Both peaks sharpen up quite significantly. That is, back of his brain immediately reorganizes at approximately that frequency, about 9 hertz. And you start seeing in frontal and central a very small peak at about 9. Corresponds to that very same frequency. We're trying to say, hey, brain tissue in the frontal lobe, why don't you wake up? Why don't you work up at 9? There's some brain tissue when we're trying to move mountains, when we're trying to wake brain tissue up, that won't shift initially and tries to stabilize in its function slower. And that's this other peak we still see at approximately 5 hertz. It's also really very high. But Eric had mentioned earlier, your anterior cingulate gyrus, this is the area that kind of gets burned out following extended drug use abuse. And we'll see this there's some addiction clinics that we service inpatient, where they kind of have to push through this, but with continued treatment and training over October 18th, we can see that 4 to 5 hertz activity now drop out. That big peak in frontal and central is not as large, and now we're starting to see the shift in dominant function in his frontal lobe, the way his brain usually works as he's walking throughout the day, now to be working in this waking state at a correspondent to back of brain 9 hertz frequency. So after all said and done, everyone starts talking the same language, same brain metabolism front and back, and we can be on the same radio station.
And I like to say, and this is everything I've learned from Alex about this. But one of the things that you've taught me is that you have to break down to build up. So if you look at that EEG where you see the middle EEG and you see this much stronger peak, the synchronized peak, the more narrow the peak, the more it means, here's a terrible analogy, the tuna are swimming in sync. So think of the neurons all firing together. The more the neurons fire together, the more narrow the peak and the higher the peak. And what we're seeing now towards the end is that he's breaking down that peak that's at an ineffective speed, and he's moving that energy into the faster speed. So we'll often see this look like the difference between a mountain that's being torn down and rebuilt in another location. You'll see this in-process time frame in the middle of a treatment session.
One last thing.
Yeah, go ahead.
One last thing I wanted to note about him, too. It kind of fits with case presentation. We're looking at disinhibition. We're looking at impulse control issues. We're looking at frontal lobe function issues. And if we're looking at his frontal lobe function and asking the question how it's working, well, metabolically and appropriately, slower than it ought to be working, and in a half-wake, half-sleep state.
So just a couple things that I want to mention that he's reflecting to us as he goes through treatments. I'm always amazed, actually, how within 2 treatments we're starting to see changes. On day 2, he had his first sleep through the night, 9:30 to 5 in the morning, in literally more than 20 years. So he immediately was sold on the sleep aspect. On day 10, he said, I have 0 cravings for alcohol. He said, I've never walked through a store without being drawn right to the alcoholic aisle. He said, I have no desire. He actually said, it's so easy, I'm afraid to believe it. And so key part of this, with people with substance use disorders, is building the network around them. He's very involved in a counseling network. He's doing meetings every day. He's doing the work. But now he has some of the power to go along with the work he's doing. Day 14, he's more tolerant in his relationships. This is a gentleman who has honestly thrashed every primary relationship in his life and has nothing left. And so at this point, being tolerant in his relationships is a big deal. Day 22, my mind is not wandering like it used to. He's now sober for 67 days today, and his PHQ-9, which is a measure of anxiety and depression, has dropped from a 10 to a 3, which is a non-treatable level at this juncture, being a 3. The next patient that I want to discuss is one of my patients who actually went on the Bredesen protocol first. He presented to my office in September of 2018. And honestly, the driving force, yes, this is the correct slide. The driving force of getting him to my office was that his wife was petrified he was going to lose his driver's license. He had failed every practice test he had taken of his written driver's exam, and if he lost his driver's license, she just could see the handwriting on the wall of things being a downward spiral. So he was having significant aphasia, couldn't remember words, couldn't remember where he was. He was a person who has been a numbers guy all of his life, keeping track, doing calculations. He had lost that ability. Had been a card shark. He had lost his ability to play cards. When we did his cognoscopy, and this was actually October 1st of 2018, when we did his cognoscopy, we really revealed that he fell classically into the toxic type of Alzheimer's with a subtype of vascular and atrophic contributors, which means he was complicated. He had major toxins in the realm of viral diseases that he had had through his life that he wasn't expressing that symptomology today when he walked into my office, but when we did the blood work, it was all there. And then the reactive and the immune reactions were all generating high inflammatory molecules in his system because of those toxic exposures. He also had high cholesterol, high homocysteine, and was extremely atrophic on things like his vitamin D and his hormone levels. His genetics were that he had 2 copies of ApoE4 and a heterozygous mutation for MTHFR, which is a folate driver in the system. So his detox in his body was impaired because of his genetics as well. So he began the Bredesen protocol on the 1st of October, a year ago, and he passed his driver's exam on December 16th. And all I can tell you, if you're not sure you want to get into this kind of work, come be in my office on a day like that, because we all cried and jumped and hooped and hollered. It was a major change. He, at that second visit, or actually it was his 3rd visit, when he came in and told me he had passed, he also had resumed counting his pills, which sounds simple, it's not simple when you realize that on the Bredesen protocol, he was taking about 25 supplements a day. So counting how many he had and whether he needed to order another bottle was a big deal to him, because once he saw the benefit of what was happening, he is not willing to let go of any single thing that's helping him. And so his own ability to start to control his own protocol instead of his wife having to do it for him was a huge celebration as well. He progressed and has done well through the spring. He has continued to improve. But in about May, when he knew we were opening this clinic with brain stimulation, he's the kind of guy that always says, what else should I be doing? And I said, come over and just let me do an EEG on you. I need to give our techs some practice. Come do an EEG. So he came and did an EEG on May 28th. And Alex, I'll let you tell us what you see here between the posterior and the frontocentrale dysynchrony.
Yeah, so we look here to begin with, May 28. We're looking for some sort of organization here in that 8 to 13 hertz range. And at that baseline EEG, you're not really seeing any peak, right? It's just this swath. So his brain is working slow, fast, in alpha and beta and theta. There's no real organization when it comes to incoming information. And he's organized frontally, but it's once again at this very slow 4 to 5 hertz frequency. That's really slow. Try to imagine only sampling 4 pieces of information per second, if usually we ought to be working about, once again on average, 9.6. It's like every other piece of information drops out. Very difficult to stay and maintain focus and concentration. So we went through treatment, and first thing that I want you to notice is in this middle graph, the posterior, we're starting to see some formation of stability. It's still largely disorganized, and the expectation is maybe we would expect to see structural issues underlying if MRIs were to be taken, et cetera. So there's a lot of work that needs to be done there, but we're starting to see a peak form here at approximately 10 hertz or so, and organization globally posteriorly as well. So the biggest thing here is just there's a little bit more organization, but when you have that large of a slow wave to begin with at 4, that's a huge, huge thing to overcome with extended periods of time. It looks like this patient just received treatment from May to July.
So he did, he did 6 weeks of treatment, which is our usual brain protocol length, and then they're snowbirds, and he left for several months. So he just got back on October 7, and I brought him back into the clinic and did this EEG on October 7, which I was actually super excited to see that he had retained what I'm seeing as activity just between 9 and 10 hertz, or it's maybe even between 8 and 10 hertz, that we're starting to see a little bump, actually, that we're seeing organized activity.
And if we look closely at the frontal and central graphs on the far right, there's a little peak at 9 as well. So this is someone who's going to need repeated treatment. We're going to have to continue to push faster frequency activities, but he was able to maintain the shift initially, and from this we can still see how much of a hill we still have to overcome when it comes to wanting to break down this 4 hertz completely and shift everything faster, if he's even capable of doing so.
Right.
In some cases, in circumstances like this, these are the cases where we might put them on several times per week, just in perpetuity in combination with the protocol, Bredesen protocol, to see to what degree we can expect to see change over time if the initial chronic period of stimulation, this daily MeRT, isn't further penetrating past and breaking down that activity.
I think one thing that none of us have said this morning is that the slowing of the brain. So how did he get to this 5 hertz frequency? You mentioned that we organize the brain when we're sub 5, when we're 2 to 4, that we organize our clock speed, so to speak, or it becomes set. But what we see is that degeneration, for whatever reason, starts to slow the brain. So if all of us have a clock speed that our brain likes in our thriving, most optimal time, life bumps and bruises us. So my speed, we've looked at mine, and I have an original speed and I have a slower speed, and I say, oh, there's obstetrics and gynecology residency, there's lack of sleep, there's whatever, right? And so when you look at the degradation of the brain that occurs over time, the sad news is that none of us are immune. Every single one of us, if we run the cognoscopy on a person who's 45, I will usually find things that person can alter and adjust for their longevity to be sustained. I am shocked that I'm finding toxic Alzheimer's signs, or those abnormal labs, in my 40 and 50-year-old patients across the board. Like 30% of them have actually had significant toxins in their blood work. So when we look at this patient, the things I can tell you from his Bredesen protocol is that he has, and these are not uncommon things, he had mono when he was 16, He's had herpes type 1, cold sores. He's had a mold exposure, and he's fallen off his golf cart. How unusual is that? Not very unusual at all. It's what every one of us knows happens in our daily lives. So when you look at those damages, the culmination for him, especially with an underlying genetic pattern of ApoE44, is that that has demonstrated clinically in him having Alzheimer's, but then also it's slowed his brain down. So we all do this. All of our brains adapt by trying to use resources better and slowing down if we need to because of the taxing lifestyle or expression and environment that we live in. Good. Thank you. I'm going to just move it forward one slide here to just say the other things about him. When he started adding MeRT to the Bredesen protocol, he began playing cards again. And he had been the leader in his club. He had regained playing cards after he started the Bredesen protocol. When he started MeRT, he began winning all his rounds again. So now he's back at the top. He's been able to resume simple calculations, and he's playing golf with no trouble keeping track of his score, and really actually functionally is back to the activities that are meaningful to him. The last case that I'm going to go through is a 26-year-old female who has a history of anxiety and concussion. And again, I want to say this is a person who walking around you would never know had a problem. And I think that's one of the things we have to get off of the pattern of thinking this is only work for people that have a major diagnosis or have signs of dysfunction, because most of us as functional human beings have a lot of dysfunction that we're managing. So this patient had 2 major concussions prior to the age of 22, similar to the patient Dr. Bredesen talked about going through a plate glass window or the front of a car. This patient had a constant level of anxiety, kind of a hypervigilance, especially notable in social settings. So imagine going to college, and what's the scene in college if you're going to be out with friends? It's a party, it's a bar, it's a club scene. And what this person found was that alcohol was really actually a key piece to just, the only reason to use alcohol was to dumb down the anxiety a little bit. So went on, did well, everything was okay and seemingly normal, but she describes that ever since the concussion, particularly the most major of the 2, she felt like there was a wall of jello between her and people around her. If we were talking, it was as if the transmission of the communication had to go through this barrier. There was always a gap between herself and the people around her, and had some difficulties with focus and attention and test taking. So this is actually her first EEG that was done on June 28th.
Yeah, and just to note, we're talking about utilization of alcohol as a compensation mechanism for anxiety that's built, but you get a feedback loop. Continue utilizing alcohol, continues to change brain metabolism, continues to slow everything down, need to utilize a little bit more, need to compensate with other things, and it helps on the symptomatology side of the house, but we still, as we're discussing today, have to address underlying issues. What's the underlying issue that has disrupted our function initially? In this example, it was a concussion, but for others, it might be underlying sleep disruption issues or metabolomic issues. But looking at baseline, we have a peak on the far bottom left-hand side of the house, and sticking with our pretty straightforward theme, we'd like to see that very same peak in central and the frontal regions. This is at approximately 12 hertz, 11 to 12. That's fast, right? But we can also see that there's little smaller activities over at 4 to 8 in both frontal and central. So even though back of our brain's working along happily, taking information in, when it comes to how well it's put together and processed frontally, well, there's a portion of brain tissue function that's working as if it's half asleep. Bit of a theme that we've been looking through so far, right? Frontal lobe function slowing down a little bit. We see some who have global dysfunction, and the clinical severity is a little bit higher. But MeRT was applied daily. Stimulation was performed, and we can see jumping from June 28th to July 29th, that there's this formation of correspondent activity in frontal and central regions. That peak moves over, speeds up, and we see that there's synchronization globally. Think of it like a tuning of radio frequency. Once again, just making it so that what we're listening to is matching with the signal that is being generated. That is, information coming from parietal and posterior occipital regions is being seen the same way that it's generated in the frontal lobe. Additional treatments delivered, and we see August 9th that from July 26th to the 9th, there's this reduction in that slow wave activity, that theta activity, as now that brain tissue function now can be relieved and jumps back up all the way up to 11 to 12.
And this is a patient, one of the things is we're differentiating our treatment from any other options. What I love about this is that by personalizing the MeRT to the speed that would work for her, we treated her brain that has an underlying faster speed than the average person in the US. We were able to dial in her treatment and help her brain fire at a speed that was its natural frequency, which I think was great by being able to personalize her treatment.
And just to note, we now advise, hey, don't go binge drinking. Don't, get your sleep. Maintain a healthy metabolic profile, because this will maintain for her. But if she were to go get another head injury, I'd ask her to avoid concussions as much as you can, right?
Exactly.
Yeah.
Well, and I think that's back to the patient with memory loss. I think that's the thing that we're noticing in patients that achieve a rate of clinical benefit, that in the patient that has memory loss, or if there's an underlying disease that is still going to degrade the brain. So for instance, if we didn't do the protocol and the patient had a folate deficiency and they had done 6 weeks of brain training and that looked great, it would not hold if we didn't correct either the underlying metabolic disorders or continue with some maintenance level of treatment. So you have to correct the underlying issues, and in some of our Alzheimer's patients, we're really seeing that this is going to be a maintenance project long term. It's not one and done. They may need to do some pattern of maintenance, and in some ways, we're still really figuring out what that pattern of maintenance should look like, because some need more and some need less.
Yeah.
So in this patient the younger patient that we just went over, that gap feeling, that jello wall between her and other people is gone. That resolved about 2/3 of the way through her treatment. The rumination, the rethinking, am I saying the right thing? Am I speaking too loud? Is everything okay? Has gone away completely. Social anxiety is resolved. Able to focus and concentrate easily. And the biggest thing she said, I have joy again. I have not had joy, and I can feel that again, which we just are absolutely super excited to work with her about.
Absolutely.
Thank you, Alex. I appreciate it. We're going to take one moment to shift the stage because we've gathered the cards that had questions from you, and we're going to take the next 15 minutes or so to do some Q&A. Thank you for being both an attentive and patient audience. I know this was a middle of the week, time out of your schedules. Thank you for coming. Please know there's contact information in the back. Dr. Bredesen's book is available widely, The End of Alzheimer's. In it, he describes the protocols that he discussed with you today. And all I can say is, let's all be well and go spread good work everywhere. We'll be up with just the panel to speak in just a moment.